if it works.
Well, I think that relates to the TV.
Oh, I don't know.
Anybody on our technical staff know whether these buttons, I think, okay, good, okay. At Friday's committee meeting, the chairman's amendment in the nature of a substitute was pending when the committee recessed. The substitute is open to amendment at any point. However, to promote orderly and thoughtful deliberation of the amendments, as I described in a memo distributed to committee members in advance of the markup, I will exercise the chair's power of recognition to give priority to amendments in order of division, starting today with Division C. I will also exercise the chair's power of recognition to prioritize recognition of members offering amendments that have been submitted consistent with a 2-hour advance submission policy I discussed in a memo to members and in previous markup sessions. I now turn to the pending amendment in the nature of a substitute.
Would the gentleman yield for a question
yes,
on timing?
Yes.
I think the chairman may be aware, may not be aware, but there are quite a few rumors floating about this markup, one of which was that we weren't even going to convene today. So you've already disproved that one, which is good. Could you inform the minority what your intention is for the rest of today, and then beyond that, the rest of this week in terms of your markup schedule?
We are going to be meeting until there are votes on the floor. Then we will break to respond to the votes on the House floor. Usually that occurs around 6:30. We will then return. The chair is providing dinner to both sides of the aisle.
And we thank you in advance.
For members so that we can continue our markup, and we'll probably go to 11 or 12.
Okay. And then the balance.
And we will be meeting tomorrow, and I think we're going to, have we decided on that issue? I believe we're going to convene tomorrow afternoon at 2.
But it is your, as of right now.
And we will then go into the evening.
It's your assumption as chairman that we're going to have a complete markup, and not, you don't see a scenario where we would suspend or stop the markup sometime this week.
We're in the markup. We'll continue with the markup. There may be changes, but that's my intention at the present.
We totally support that on the minority. We, as you know, have a number of amendments, and we fully look forward to a positive and constructive markup process this week in this committee.
Thank you.
Thank you.
So we have pending before us amendment in the nature of a substitute. The Republicans would go first with an amendment, since we've got, so last amendment we considered on Friday was on the Democratic side. Mr. Deal, you're seeking recognition.
Yes, I do.
What is the number of your amendment?
The number I have is 298, mandates on states number 3.
Let me ask the clerk before we consider that amendment. Is this an amendment to Division C? Was the amendment submitted with 2 hours lead time for committee review, and are there copies for distribution at the desk?
One moment, Mr. Chairman, we're checking.
Okay.
I know.
Mr. Deal, what's your number again?
Deal 201.
Your number of your amendment?
201. Yes, sir.
201?
Mr. Chairman, I'm informed it's 201.
201.
I'm sorry.
It's been there since Friday.
Yeah. Clerk will, I asked the clerk a series of questions.
We have it, Mr. Chairman.
I asked the question of whether this relates to Division C.
It does.
2 hours in advance, and you have amendments to distribute. Okay,
Yes.
The answers are in the affirmative. The clerk will report the amendment.
Amendment offered by Mr. Deal of Georgia. In Title V.
Without objection, the
Division C
amendment will be
strikes-
considered as read, and I recognize the gentleman from Georgia to speak on his amendment. Thank
the Chairman. Mr. Chairman, this amendment relates to the authority of the Health Choices Commissioner and would restrict that authority so that he could not deem a state that offers a state health insurance plan to its state employees as being out of compliance with a federal standard. As we all know, our states choose to offer plans of health insurance for their state employees and those who under their state law are entitled to coverage. And I do not think that it would be the intent of this body to allow this federal Health Choices Commissioner to, in effect, override the decision that has been made by the elected officials at the state level as to what they think is appropriate to be offered to their state employees. And this amendment would simply clarify that fact. Let's take, for example, we do not know for sure what would be a mandated coverage question, but let's assume that it may be something as at the federal level that would mandate that an abortion or a Botox or things that might be out of the mainstream be required at the federal level, and a state plan might not offer that. I don't think we would want the state to be told that they're going to have to pay an 8% employer tax for being out of compliance with the federal standard. And that is the gist of the amendment, and I would urge its adoption. I will yield back.
Gentleman yields back his time. Who wishes to be recognized on the amendment? Well, the chair will recognize himself for 5 minutes. As I understand this amendment, while it we're considering it in Division A, it would ordinarily be thought of as something that would come up later in the bill, but it is a provision that does only one thing. It requires the state and local governments in their roles as employers to follow the same rules that all other employers must follow, no more and no less. And the gentleman for Georgia would strike that requirement in the legislation. It is in the Public Health Service Act part of the bill, unlike what other employers being covered under Division C, because if the governments don't provide what the other employers would be required to do, then they wouldn't be eligible for federal funds under the Public Health Service Act. And this is the way this committee has reached other requirements, such as the COBRA insurance continuation and other matters that relate to local governments. We don't rely simply on mandates that are in Part A, because there are some in the legal community that argue that under the Constitution, the federal government can't simply order the states to do things. So what we say is that the states don't have to do this. They don't have to provide their own employees coverage. But if they don't give their own employees coverage, they're not going to get funds from the federal government. And in all 50 states, local governments are created by state law. They may be called cities or counties or parishes, but they're creatures of the state. And the statutory language requires the states to assure that localities will comply in the same manner as the states do. It doesn't cut off funding immediately, it allows flexibility for the states to work with localities to come into compliance. If we're trying to get people in this country covered with health insurance, we think that governments at the state level and the local level should provide insurance coverage for their employees as well. And the gentleman from Georgia's amendment would strike that requirement, and we think that requirement should stay in the bill. So with all respect to the gentleman from Georgia, I disagree with his amendment and urge members to vote against it. Further discussion. Mr. Barton.
Mr. Chairman, I'm going to rise in support of the amendment, but before I do that, I have a question or two for the council. Under the provision that Mr. Deal is attempting to strike with regard to the states, is it true that if we don't strike this and the bill stays as is, that the federal government could withhold grants from states if they didn't comply with some of the mandated requirements for health coverage of their state employees?
Yes, sir.
It is a true statement.
Yes, sir.
Well, that's a straight answer. Okay. Is it true under the provisions of the bill, if not struck or amended, that if the federal government required abortions to be covered, a state would have to do that or it could lose grants?
If the Secretary acting on advice of the Benefits Advisory Commission had made abortion a minimum benefit for any acceptable insurance package, yes, sir, they could withhold that.
Okay. Thank you. And thanks for the non-technical answers. I appreciate that. Well, Mr. Chairman, I do want to oppose this. I want to support this amendment and oppose the base text of the bill that Congressman Deal is attempting to amend. I don't think too many members of this committee really want to tell us a sovereign state of the Union how to manage their health care plans, and I certainly don't believe we want to give a commissioner, if I understand the bill's term right, the authority to enforce those health mandates by withholding grants. I'm only aware of one provision in federal law where currently we give an administrator or a cabinet secretary the ability to withhold grants. In the Clean Air Act, we do give the EPA administrator, I don't know if we give the direct right to withhold highway funding, but we certainly, it is an option that the EPA administrator can use when trying to get states to enforce or to comply with certain of the requirements of the Clean Air Act. And that particular authority has been threatened repeatedly, but I'm not aware that it's ever been used, unless it may have been used once for the city of Atlanta.
Well, maybe counsel can answer that question if it's ever been in the statute before or ever used.
Mr. Barton, Mr. Waxman, this provision is modeled on one that is already in current law for the provision of COBRA continuation benefits for health insurance that require employers to provide 18 months of coverage after severance. It has been in law for 25 years, also subjecting all public health grants to jeopardy if the state were not to comply. There has been no non-compliance, and no state has lost eligibility from this provision.
Well, it's a huge. I'm happy to yield to the chairman. Sure.
We're telling employers that we want them, that if they're going to provide health insurance to their employees, to meet a minimum standard. Why not tell the states as employers to meet a minimum standard as well? The difference is we can't tell the states what to do directly. We have to use whatever leverage we have over them. The Constitution says you can't tell states what to do, but we could put a condition on it. If states want public health money from the federal government, one of the conditions would be that they are going to treat their employees as fairly as any other. The other point I wanted to make is your question about abortion was a hypothetical question, not a real one.
Well, that's a real question.
Well, it seems to me highly unlikely that the Secretary is going to demand that every plan in this country have abortion services. And I think we'll probably have amendments to that in that regard.
With the gentleman, Texas yield.
Let me make a point. The chairman's support of the amendment, to me, is an eloquent statement of why we shouldn't do it. It is chilling to me that we're on the verge of preempting state sovereignty and telling states, pressuring states what they have to do. Why have a state? If what the chairman just said is the I don't know how to say this, is the no, I'm not. if that is the philosophy behind this bill, it really calls into question the federal system.
Would gentlemen,
My time has expired. Can I have
Without objection,
one additional minute?
gentleman will be given one additional minute.
And I will yield to the author of the amendment.
I thank the gentleman. I would simply point out that this amendment will keep you from having to explain to your governor, to every member of your legislative body at the state level, potentially to every mayor and every city council in every city and municipality in your state, why they cannot choose the kind of health insurance policy that they want to offer to their employees. If the thrust of this bill has as its premise covering the uninsured, state employees are not uninsureds. Local municipality employees are not uninsureds. Why do we want to take this bill to the level of taking away all state rights, all local control on issues as fundamental as this? And if this amendment is defeated, you will in effect be doing exactly that. And I would thank the gentleman for
If I still have 30 seconds, there's just a basic philosophical difference between the majority and the minority, or at least between the chairman and Congressman Deal. We think competition in the marketplace is the way to provide the best health care plans. We certainly think states who don't normally pay as well as the private sector, but most states do have premium health care plans, should have the right to pick and choose and to develop the health care plans they provide to their employees. We do not believe, we on the minority side, that what we really want to do is create a system where a federal health commissioner is telling the states what they have to do in terms of their health coverage. So I would strongly support Congressman Deal's amendment. Thank you, Mr. Chairman, for the extra.
Gentleman's time has expired. Mr. Stupak.
Thank you, Mr. Chairman. You know, we brought up this amendment for everything from Botox to abortion. I just want to assure members, over the weekend, Mr. Waxman's staff and our staff, we all been working on compromise language not to preempt, so we do not preempt state laws in regard to abortion services. And that debate will really come up in Division A. So I'd hope we would vote against this amendment. Mr. Waxman and I and all the staff's been working in good faith. This isn't, they're just, I hope we don't start throwing out abortion or reproductive services on every amendment we want to get through. There is a meaningful place where they come up legitimately in this legislation, and we're prepared to offer some amendments at that time, and we'll have our vote then. But I hope we're not going to start using reproductive rights as a red herring on every argument that comes up. So I'd hope we'd vote no on this piece of legislation. I'd yield the remainder of my time to Mr. Pallone.
Thank you. Yeah, I guess I'm just a little confused about what my colleagues on the other side of the aisle are saying, because all we're really doing here is saying that the state has to act like other employers, you know, your benefit package, whatever it is that they, you know, that we're requiring of other employers, that they would have to do the same thing. So I guess I philosophically don't understand if the other side is saying the state shouldn't have to do that, then you're going to have you know, people who have private employers doing one thing and, you know, putting certain requirements on that the states don't have to adhere to as employers. And it seems to me that that's not fair. And I don't know any other way to do this. I mean, this is like a hook that, as was explained, that we've used in COBRA and HIPAA and others to, you know, basically say if they don't do it, they're not eligible for federal funds under the Public Health Service Act. But I wouldn't want to see a situation where states didn't have to do what other employers do, whether it's the benefit package or whatever it happens to be. So I think I understand what my colleagues on the other side are saying, but I think that it's the wrong way to go. We should say that states have the same obligation as other employers, and this is the best way to proceed, and one that's already been tried and with COBRA and works. I yield back, Mr. Chairman.
Gentleman yields back the time. Further debate, Mr. Boyer.
Thank you, Mr. Chairman. I'll be brief. I just want to make this note. Both political parties will do this. It seems like we like to pick and choose when we want to set a federal standard and preempt, and when we want to then fight for states' rights. And we're all subject to that. So I just want to pause, though, and remind us that if, in fact, we want to set a federal standard, there better be a basis in fact for that overarching federal interest. So for example, Mr. Chairman, when I made an amendment when we did the tobacco legislation to set a federal standard on fire-safe cigarettes, you said no. You said, no, Steve, we're not going to have, we're not going to override the states. Now you're arguing the complete opposite. But I just want you to know, even as I have voted for a federal standard for medical malpractice. So I will recognize that we do pick and choose when we want to have a federal standard, when in fact we want to give respect to our states. But if we're going to set that federal standard, I just think we need a good basis to say why we want that overarching federal interest. I yield back.
Further discussion of this amendment? Yes, Mr. Gingrey.
Mr. Chairman, thank you. The question was put to General Counsel by Ranking Member Barton. Could the Secretary, under this bill, could the Secretary tell the states that they would have to have a plan that covered, hypothetically you say, abortion? And I understood the General Counsel said, yes, she could do that. He could do that. And then, Mr. Chairman, you said, well, I don't think that she would do that. In fact, we'll probably have some amendments that will come up later on in Division A or Division B to speak to that. Well, you know, here we are at the very outset addressing a problem that my colleague from Georgia, the ranking member on the Health Subcommittee of Energy and Commerce of this committee, recognized and has an amendment, a straightforward common sense amendment, where it makes sure that that would not happen. Why should we put off that issue until we get to Wednesday or Thursday or Friday or next week or whatever? Let's deal with it right now. I support the amendment. I hope my colleagues on both sides of the aisle support the amendment. It's clearly stated. There's no ambiguity. Let's prevent this, and let's prevent it right now. And I yield back.
Thank you, Mr. Gingrey. Further discussion on the amendment? If not, we'll proceed to a vote. All those in favor of the Deal amendment say aye. Aye. Opposed, no. No. The noes have it. The amendment's not agreed.
I would ask for a roll call, Mr. Chairman.
The gentleman requests a roll call vote. Let's proceed to a roll call.
Mr. Waxman.
No.
Mr. Waxman votes no. Mr. Dingell. Mr. Dingell, no. Mr. Markey. Mr. Boucher. Mr. Pallone. Mr. Pallone votes no. Mr. Gordon. Mr. Gordon, no. Mr. Rush. Mr. Rush passes. Ms. Eshoo. Ms. Eshoo votes no. Mr. Stupak. Mr. Engel. Mr. Engel votes no. Mr. Green. Mr. Green, no. Ms. DeGette. Ms. DeGette, no. Mrs. Capps. Mrs. Capps, no. Mr. Doyle. Mr. Doyle votes no. Ms. Harmon. Ms. Harmon, no. Ms. Schakowsky. Ms. Schakowsky votes no. Mr. Gonzalez. Mr. Gonzalez, no. Mr. Inslee. Mr. Inslee, no. Ms. Baldwin. Ms. Baldwin, no. Mr. Ross. Mr. Weiner. Mr. Weiner, no. Mr. Matheson. Mr. Matheson, no. Mr. Butterfield. Mr. Butterfield, no. Mr. Melanson. Mr. Melanson, no. Mr. Barrow. Mr. Barrow, no. Mr. Hill. Mr. Hill, no. Ms. Matsui. Ms. Matsui, no. Mrs. Christensen. Mrs. Christensen, no. Ms. Castor. Ms. Castor, no. Mr. Sarbanes? Mr. Sarbanes, no. Mr. Murphy of Connecticut? Mr. Murphy, no. Mr. Space? Mr. McNerney? Mr. McNerney votes no. Ms. Sutton? Ms. Sutton, no. Mr. Braley? Mr. Braley, no. Mr. Welch? Mr. Welch, no. Mr. Barton? Mr. Barton votes aye. Mr. Hall? Mr. Hall, aye. Mr. Upton? Mr. Upton, aye. Mr. Stearns? Mr. Deal? Mr. Deal votes aye. Mr. Whitfield? Mr. Whitfield, aye. Mr. Shimkus? Mr. Shimkus, aye. Mr. Shattuck? Mr. Blunt? Mr. Boyer? Mr. Boyer votes aye. Mr. Radonovich? Mr. Radonovich, aye. Mr. Pitts? Mr. Pitts, aye. Ms. Bono Mack? Ms. Bono Mack, aye. Mr. Walden? Mr. Walden, aye. Mr. Terry? Mr. Terry votes aye. Mr. Rogers? Mr. Rogers, aye. Mrs. Myrick? Mr. Sullivan? Mr. Sullivan votes aye. Mr. Murphy of Pennsylvania? Mr. Murphy, aye. Mr. Burgess? Mr. Burgess, aye. Ms. Blackburn? Ms. Blackburn votes aye. Mr. Gingrey? Mr. Gingrey, aye. Mr. Scalise? Mr. Scalise, aye. Mr. Markey? Mr. Markey votes no. Mr. Stupak? Mr. Stupak votes no. Mr. Rush? Recorded as passing. Mr. Rush votes off, pass on no. Mr. Ross? Mr. Ross votes no.
15 minutes.
Mr. Space? Mr. Space, no.
Brief everybody on it. It's
Do
just
you want a
not
caucus?
Mr. Shattuck?
let
Mr. Shattuck votes aye.
the minority committee staff brief the members' personal staffs, because some of them are just not getting back. I mean,
Have all members responded to the call of the roll? If so, the clerk will tally the vote. Clerk will announce the vote.
On that vote, Mr. Chairman, there were 20 ayes and 35 noes.
20 ayes, 35 noes. The amendment is not agreed to. Okay. Ms. Sutton, for what purpose do you seek recognition? You have an amendment at the desk?
I do have an amendment at the desk, Sutton 3.
My inquiry to the clerk before we call up the amendment is first of all, is this an amendment to Division C? Was the amendment submitted with the 2-hour lead time for committee review, and are there copies for distribution at the desk?
Yes.
And it's Sutton 7.
Okay. Is it 7 or 17?
Is the clerk ready to report the amendment? And has the amendment
It's to
met the
Division C.
qualifications?
Yes, sir.
Okay. Please report the amendment.
Amendment offered by Ms. Sutton of Ohio.
I don't know which one it is.
Without objection, the amendment will be considered as read. The gentlelady from Ohio is recognized for 5 minutes.
Mr. Chairman, I reserve a point of order.
The gentleman from
Which
Louisiana
amendment is?
reserves a point of order.
Thank you, Mr. Chairman. If I could just get a point of clarification from the clerk. The amendment number is?
It is Amendment Sutton 3_001.
Oh, thank you. Mr. Chairman, this is a very easy to understand amendment. It is an amendment that within the America's Affordable Health Choices Act, there's a clause which creates a national prevention and wellness strategy to better the overall health of Americans. That's in Section 2301A. And this amendment would include the Substance Abuse and Mental Health Services Administration among the agencies that the Secretary is directed to consult with regarding development of the National Prevention and Wellness Strategy. SAMHSA, which is the Substance Abuse and Mental Health Services Administration, is within the Department of Health and Human Services. And as we know, Mr. Chairman, mental health and mental illness and substance abuse are some of the most costly and disabling conditions affecting the U.S. population. Severe mental illness costs the U.S. $193 billion in lost wages in 2002, which exceeds the gross revenue of 499 of the Fortune 500 companies. Mental illness often accompany and greatly increase the costs of treating other chronic conditions, including diabetes, asthma, heart disease, and obesity. But nonetheless, mental illness and substance abuse are often overlooked in discussions regarding prevention and wellness. It occurs despite the fact that there's a large body of research showing that effectiveness of many interventions at preventing mental illness and substance abuse, and it would help us reduce our costs in the long run. SAMHSA would be well equipped to advise the Secretary on how to best incorporate the findings of the IOM and prevention of behavioral health disorders more generally into a national strategy. SAMHSA includes mental health promotion and substance abuse prevention as core elements of its mission, and the agency maintains a national registry of evidence-based programs and practices for the prevention and treatment of mental and substance abuse disorders. And with that, Mr. Chairman, I will yield back.
Will the gentlelady yield?
I will yield.
I have no problem with the explanation you gave, but I would appreciate it if you could tell me if this community prevention and wellness activities section of the bill is where there is funding for bike paths and lighting, which has been written about broadly in the press, including, I believe, in the Boston Globe. Does the gentlelady know?
I'm unaware of that, no.
Maybe I could ask counsel.
Give me 1 second, sir. Oh. Do you know where 3120?
I can say that that has nothing to do with my amendment.
I understand that. I'm simply trying to find out if this is that section of the bill.
No, sir. This occurs in the provision setting up the strategy. It does not occur with any authorization of appropriations at all.
Okay. So can you tell me where those funds are?
Yes, sir. They are, I believe, further on in subtitle.
Reclaiming my time.
If counsel will answer that later, I appreciate the gentlelady for yielding.
Certainly. Reclaiming my time, and with that, I will yield back.
Gentlelady yields back her time. Mr. Barton?
Well, Mr. Chairman, I was a little confused by what Mr. Shadegg just questioned, but the amendment that's actually before us, we support. Yeah, this amendment, this AAHCA 09/001 is unobjectionable. We're supportive of
that is the amendment that the gentlelady from Ohio has presented to us. Any further debate on that amendment?
Withdraw point of order. Withdraw the point of order.
Okay. Gentleman from Louisiana withdraws his point of order. Are we ready for the vote? All those in favor of the Sutton amendment will say aye. Aye. Opposed, no. The ayes have it, and the amendment's agreed to. Further amendments. Mr. Gingrey. You have an amendment at the desk?
Mr. Chairman, I do. It's 14A-001.
Mr. Chairman, I reserve a point of order.
I ask the clerk the following questions again. Is this to the subtitle that is under consideration? Has it been available for 2 hours, and do you have copies to distribute?
Mr. Chairman, yes, to all those questions.
Answer in affirmative to all those questions. The clerk will report the amendment.
Amendment offered by Mr. Gingrey.
Without objection,
Section
that amendment will be considered as read, and the gentleman from Georgia, Mr. Gingrey, is recognized for 5 minutes.
Mr. Chairman, thank you very much. This amendment would prevent any federal employee or political appointee to dictate how a medical provider practices medicine as a result of the development of best practices by the Center for Quality Improvement. Mr. Chairman, doctors and their patients are really sacrosanct, and the doctor-patient relationship is extremely important. The Center for Quality Improvement, as I understand it in this bill, is similar to the NICE organization in the UK health system, the National Institute for Health and Clinical Excellence, that makes decisions under their system that basically denies certain coverage. And I would reference particularly in cancer therapy, chemotherapy, wherein the results that the 5-year survivability of prostate cancer and breast cancer is significantly less than it is in the United States under our current system. And Mr. Chairman and my colleagues, that is simply because this so-called NICE oversight group makes decisions based on cost and not necessarily clinical effectiveness. I have no objection to the Center for Quality Improvement to do research, hopefully scientific research, to come up with what appears to be best practices for each and every disease. But they have to take into consideration the fact that patients vary. And who knows that better than the doctor that maybe has been treating that patient for 25 years, who specializes in a particular disease, whether it's diabetes or cancer, and knows that, that this patient is on medications that might conflict with a certain treatment that happens to be found to be the best practice by the Center for Quality Improvement, the least costly, let's say, but yet the doctor knows that this patient should not take that drug and that there is a better drug for him or for her. You know, when we heard last week on, I think it was Monday, the director of the Congressional Budget Office, Mr. Elmendorf, and he talked about the fact that in looking at this bill and looking at the bill that was passed by the Health Committee in the Senate, there's unfortunately a bending of the growth curve in regard to the cost of health care, but it's bending in the wrong direction. So my fear, in the purpose really of this amendment, my fear is that when we sign up 97% of the people in this country for health insurance, universal coverage, near universal coverage, that we're not going to be able to meet those obligations. And it's going to be like Noah's Ark, and you've put too many people on the ark, and all of a sudden it may take a couple of years, but it begins to sink. And so you decide that you have to get rid of some of that baggage. You begin to throw people overboard. And who gets thrown overboard first? It's the sickest. It's those who are suffering from multiple illnesses. It's our seniors, our precious seniors, that get thrown overboard. And so I think it's very important, Mr. Chairman and my colleagues, that we don't let that happen, that doctors are smart enough to understand what the Center for Quality Improvement says what works best. They are going to take that into consideration, strong consideration, but they can't be forced, or should not, I should say, be forced to practice under the dictates of some federal employee or political appointee who has really no medical background. They may be good at business. Indeed, they may be even a former governor. But they haven't practiced medicine, and they don't understand the importance of this. And so, Mr. Chairman, I would ask colleagues on both sides of the aisle, I would hope that everybody would agree with me that this amendment needs to be in there to protect these patients, and so that doctors can continue to practice medicine as they see best, taken into consideration, of course, the recommendations for best practices, but not be dictated in regard to how they can treat. And with that, Mr. Chairman, I'll yield back, or I'll yield to one of my colleagues on either side.
Mr. Chairman.
Gentleman yields back his time. Who seeks recognition?
Mr. Chairman.
Well, we'll go in order of seniority. Mr. Shkowski?
I have no problem if she wants to go first.
Mr. Shkowski, you're recognized.
Thank you, Mr. Chairman. I'd like to speak against this amendment, and here's why. This amendment says that this would not allow any, quote, federal employee or political appointee, unquote, at the Center for Quality Improvement, quote, to dictate how a medical provider practices medicine, unquote. Well, this is very, very broad language. So consider the checklist for healthcare-associated infections, as written up by Atul Gawande in the New Yorker last year. This is an innovation that both sides of the aisle have hailed as a major advance in care. When doctors follow a simple 5-step checklist when doing certain procedures, certain types of healthcare-associated infections can be nearly eliminated, saving tens of thousands of lives and millions of dollars if implemented nationwide. If the center were to try to assist in the implementation of the checklist, this could easily be construed as, quote, dictating the practice of medicine, unquote. But the checklist is exactly the prototype for what we want the Center for Quality Improvement to develop. And this language could prevent the Center for Quality Improvement from carrying out its essential task to develop new and innovative best practices to improve the quality of health care in the United States. Scientific advances, if done properly, should change the practice of medicine. We would never pass a law that said to the National Institutes of Health that if they develop a new life-saving therapy, doctors shouldn't use it or couldn't use it. That's exactly what this amendment says. I urge my colleagues to vote against this
Will the
amendment.
gentlelady yield?
Yes, I would yield, happily.
Just to add to the broadness of this amendment, I would agree that we want to really think that we don't want to deal with how doctors practice specific medicine with their patient. But this is so broad. This could go to the rates that doctors charge, or this could go to overuse of tests, or it could go to many of the provisions that we're trying to get at with this bill to improve the quality of medical practice while at the same time making it more cost effective. And so while it looks appealing on the face, I think this is going to go, I think this will undermine the whole legislation, and I'd urge a no vote, and I yield back.
Gentleman from Illinois yields back the time. Further recognition. Mr. Barton.
Mr. Chairman, I rise in support of the Gingrey Amendment. It is simple. I'm going to read it. Nothing in this section shall be construed to allow any federal employee or political action or political appointee, to dictate how a medical provider practices medicine. Practices medicine. Doesn't say bills for medicine. Doesn't say researches. It says practices medicine. Now, if the majority is right, and Congresswoman DeGette and Congresswoman Schakowsky really don't want to prescribe how doctors and healthcare professionals practice medicine, we ought to accept it, because all Dr. Gingrey is attempting to do is make sure that these new components in the legislation don't end up actually giving bureaucrats the power to tell doctors how to practice medicine. If that's not the intent of the authors of the legislation, this ought to be accepted by unanimous consent. We're going to make this point over and over and over and over and over again in this markup. Most of us on the minority side believe in the marketplace, we believe in transparency, we believe in choice, we believe in letting diversity. You know, we're not opposed if you want to put out a checklist for best practices. In fact, the next amendment that the minority is going to offer is one by me on transparency. If you want to put out results of surgeries, and if you want to put transparency into pricing, we're all for that. If you want to compile best practices and most innovative research and make that available, you want to do, you know, health, internet technology, health IT, we're all for that. But what we're not for, you create so many new bureaucracies, so many new positions of potential authority and mandate in Washington where people that are not trained doctors have the ability to dictate to the medical community how to practice medicine. Practice medicine. That's why Dr. Gingrey is so straightforward in this. You know, it's not technical language. Simply, we do not want the bureaucracy created under this provision, under this bill, or the presidential appointees of either political party, if this bill becomes law, having any hint of the ability to tell our medical professionals how to practice medicine. That's why
the gentleman will yield.
I'll be happy to.
And I appreciate the ranking member yielding to me for a second. You know, what he's saying is exactly my intent. The argument about not following best practices as determined by the Center for Quality Improvement or NICE or whatever the committee is called in whatever country, I'm not opposed. I think doctors should pay attention. They should follow best practices. If it's a 5-step process, protocol, or a 12-step protocol, I think that most physicians would follow that suggested protocol. But let's say a situation where a neurologist has found that in the last 3 cases where he suspected that a patient may have a malignant brain tumor, that he ordered a CAT scan. And the report was negative, that there was no evidence of a brain tumor, but his clinical acumen, his gut feeling, if you will, told him that there was something wrong with this patient. And so he felt like a more expensive test, yes, but an MRI should be done. And these cancers were detected. And these patients had an opportunity at a very early stage to get the appropriate chemotherapy. And not just improve their 5-year survivability, but hopefully to cure them. I think a doctor in that situation would be willing to, you know, if the Center for Quality Improvement wanted to slap him or her on the wrist and say, we're not going to reimburse you as much, we're not going to pay you as much, they would be gladly acceptance of that lesser payment if they had, in the final analysis, the continued right to make those decisions which they knew was best for their patients. And I yield back to the ranking member.
I support the Gingrey Amendment, and I yield back.
Gentleman's time has expired. Yes, Mr. Pallone.
Thank you, Mr. Chairman. I just want to stress, because of what the previous speaker said, whatever innovations or practices that the Center for Quality Improvement suggests or develops are not linked to a reimbursement rate or mandated, you know, on physicians. The concern that I have is that with the Gingrey Amendment and this language, that you kind of throw water on innovation. In other words, you suggest that somehow you know, they shouldn't develop these practices because they may somehow hinder a physician from practicing medicine. And that's not the case. There's nothing that they would develop that would be mandatory, or say that a doctor wouldn't get reimbursed if he didn't do it. So the language really isn't necessary. The only thing that the Gingrey language would do, in my concern, is that it's going to, you know, hinder the development of these practices, because there's going to be some fear that somehow we're interfering with the practice of medicine. I just want to stress, though, that there's nothing in here that's a mandate or links to the reimbursement rate, because I know there was some suggestion of that on the other side. I'll yield to the gentleman from Maryland.
Yeah, just to echo that, I mean, I don't think any of us in opposing the amendment are suggesting that we think doctors should be told how to practice. I think the concern is, and it's ironic because the name of this is construction, but I think we're concerned that this provision could get construed in a way that would end up discouraging the kind of best practices implementation, which you agree ought to happen anyway. So I think it's the language of this and the potential for it to get construed such that you then create barriers to the encouragement of best practices, which is what CQI is trying to do and we want the Secretary to be engaged in. So that's the problem with it. It's not that we want to stand in the way of what the physician wants to do. We're worried this could end up working against best practices. Feel bad.
Gentleman's time has expired.
Mr. Chairman. Chairman, I withdraw my point of order.
Yes. Yes, gentleman from Illinois.
Thank you, Mr. Chairman. A lot of these comments, I want to read this from the July 7th Wall Street Journal. The British officials who established NICE in the late 1990s pitched it as a body that would ensure that the government-run national health system used best practices in medicine. As The Guardian reported in 1998, health ministers are setting up NICE designed to ensure that every treatment, operation, or medicine used is the proven best. It will root out underperforming doctors and useless treatments, spreading best practices everywhere. That is exactly what I hear my colleagues on the other side saying. What has NICE become? NICE has become, in practice, a rationing board. As health care costs have exploded, even in this bill, the CBO has projected that the health care costs will explode. In Britain, as in most developed countries, NICE has become the heavy that reduces spending by limiting the treatments that 61 million citizens are allowed to receive through the NHS. For example, in March, NICE ruled against the use of 2 drugs that prolong the life of those with certain forms of breast and stomach cancer. After last year's ruling, Peter Littlejohns, NICE clinical and public health director, noted that there is a limited pot of money, that the drugs were of marginal benefit at quite often an extreme cost, and the money might be spent elsewhere. The board restricted access to 2 drugs for macular degeneration and blindness. In fact, they recognized, they allowed this drug, this guy was going blind in 2 eyes. And they said, okay, we'll pay for the drug in 1 eye, but you can go without the other eye. NICE has limited the use of Alzheimer's drugs. NICE rulings include the rejection of Kenret, a drug for rheumatoid arthritis. NICE has also produced guidance that restrains certain surgical operations. NICE is the target of frequent protests and lawsuits. The NICE board even has a mathematical formula for doing so based on quality-adjusted life year. I'm telling you, folks, if we move down this direction to socialized medicine on the best intentions of best practices, we're going to end up with a rationed healthcare system where people who need care will have to try to find some other country to go to, and you guess what? They're not out there. So if you want to set up this quality board and you want them to subvert Dr. Gingrey's and the doctor-patient relationship on the best intentions, as they did in England in 1998, go ahead. But we're not going to be any part of it. I yield back. I yield my Congressman Shadegg.
I thank the gentleman for yielding, and I think this is really very straightforward, and it is very fundamental. Read the words of the amendment by Dr. Gingrey. It says that a federal employee or political appointee may not dictate how a medical provider practices medicine. If you oppose that, then you have decided that A federal bureaucrat should be able to, can dictate how a medical provider practices medicine. If you're going to do that, then you're going to assume medical liability for every decision that you mandate. This has nothing to do with suggesting best practices. This has nothing to do with informing doctors of what is the least expensive form of care or the most effective form of care. Indeed, if a doctor were advised that the best practice was to do what was suggested and then he didn't do it or she didn't do it, that would be malpractice if it in fact caused any harm, and indeed they could seek a remedy for that. This is not a question of innovation. Indeed, innovation can come from doctors as well as from government boards. But the question is, do you want to put the doctor between, to put the federal government between a patient and his or her doctor? I would suggest to you that the practice of medicine is in part science, where we can make suggestions as a federal government to doctors as to what they should or shouldn't do, what's cost effective and what isn't cost effective. But if you think that we should have federal employees telling doctors how to practice medicine, then we are abandoning medicine as is taught in America's medical schools in this country, and I think the AMA better listen up, because you're embracing the notion that a bureaucrat is going to tell your doctor how to practice medicine. If that happens, we're giving up all form. Pick up a dictionary, look up the word dictate. It says mandate, command, compel. Read how. It's clear. Should we give this power to the government or keep it in the hands of doctors? I yield back the gentleman's time.
Gentleman's time has expired. Who seeks recognition? Mr. Green.
Thank you, Mr. Chairman. Having worked on health care, both in insurance, health insurance issues in the legislature and now for a number of years on the committee, the amendment is so simple it almost seems so easy, but it's probably the ultimate and gotcha amendment. And I've listened to my arguments on my Republican colleague's side that we've got United Kingdom with socialized medicine making decisions. This is not a socialized medicine bill. It is not, no matter how much you say it is, it's not. We're taking advantage of the 60% of the folks who get their health insurance through their employer now, and that's going to be continued. Whatever we plan for this is not anywhere near a single payer like the United Kingdom has. Brought up medical malpractice, that if we don't pass this, that the federal government could be ultimately the person who gets sued. We're not practicing medicine in this bill. Nothing in this bill dictates medical practice any more so that since 1965, Medicare hasn't told doctors how to practice. Now, I bet you this amendment could have been germane in 1965 when Medicare was created. And we can go back and see, does Medicare actually tell somebody? No. They tell you what you're being reimbursed for. Blue Cross does that right now with my insurance. Blue Cross does it with my insurance. It did it with when I was a state employee. It did it when I was managing a printing business. We didn't have Blue Cross. We had other insurance companies. That's what's happening now. But this bill doesn't allow any federal employee to do that. In fact, I would say that if you make that argument against this legislation, then maybe you should have made it against Medicare, which is probably the second most popular domestic issue in our country, only compared to Social Security. This is not a national health care like the United Kingdom. It's got so many variations of it. I guess the closest you could get is probably like the Netherlands, who had a national health care, then backed away from it. They have an individual responsibility. They have an employer responsibility. That's what's in this bill. So this is such a simple amendment, but it really has no bearing on this bill because it has nothing to do with a federal employee telling a doctor how to practice medicine. And that's why the amendment should be voted down. If not, I'd consider it non-germane since we really don't have a federal employee provision in here, a political appointee who can tell someone, a doctor, how to practice medicine. And I'll yield back my time.
Further debate on the Gingrey Amendment. Mr. Rogers.
Thank you, Mr. Chairman. This, to me, gets to the heart of the debate, and I take the gentleman at his sincerity But it is, if you read this bill, it is a bold-faced lie and disingenuous to tell the American people, if you want to keep your health insurance that you'll have, if this passes, you'll be able to keep it. There are perverse incentives in this bill. That is if your employer keeps it. Go out and ask your employers if you can pay an 8% payroll tax or pay 15% per employee for health care, what decision will you make? They are going to make in droves. The Lewin study shows 114 million people will be shoved off of their private plans onto the government plan because employers don't want this hassle to begin with. You've set up in the bill a very perverse incentive for them not to offer health care to their employees. It's pretty dangerous. And the one thing, and the President certainly found this out last week, the one way that government controls costs in health care is by rationing care and or by reimbursing at a rate less than cost. Welcome to Medicaid and Medicare. So now you have 100 million people getting shoved over on a plan that doesn't quite reimburse at the right rate, and now you've got a huge problem. And oh, by the way, we used to make up that difference by the number of people on private insurance. Oh, that's right. We're shoving 100 million people off private insurance. Where does the money come from? So this notion that you can tell people and look them in the eye and say, no, you'll get to keep it if you want it, only if your employer offers it. And there is every incentive. Go back, don't take my word for it. Talk to your employers back there. Talk to the small guys. Talk to 100 people employees. They can't wait for this to happen because they're going to shove their people off of their private insurance.
Well,
because
gentlemen,
it saves them money. Well, just a minute. I'm going to tell you another story and why comparative effectiveness is so dangerous to me. And I tell you what, I wouldn't ask my mother or my daughter to go into a system that I know would not allow them to survive breast cancer at the same rate that we have the ability today. And that happens. And I'll tell you why. Let me give you a great example. A 19-year-old presents to the doctor with blood in the urine. Healthy 19-year-old, very athletic, playing football. The doctor's practice comes to the conclusion that person's been jarred. Take a few days off of football, you'll be fine. Thankfully, a doctor in that practice said, you know, I've watched this patient for 15 years. Something's not right. Doesn't seem right. I can't quite tell you. I've reviewed the tests. I want to do further tests. Everyone in the practice says, nope, don't do it. It's crazy. 19 years old, this is all it is. Thankfully, that woman doctor wins out. That patient goes down to a urologist and finds out that they have bladder cancer. The statistics of that were almost impossible to be true. But had that doctor not been able to act on her hunch and her medical science and her history with that patient would have been dead at 26. That patient was me. I take this very seriously. And when you start talking about getting involved between a doctor and a patient, and this bill will do it, don't kid yourself, this bill will do it. You do it through best practices, you do it through comparative effectiveness. It's the only way you can cut costs. They would have said, statistically, you can't have that person can't have bladder cancer. That person shouldn't have that treatment. That's exactly what they do in Canada. It's exactly what they do in Great Britain. It's exactly what they do in Denmark. And you know what? Just real quickly, if you look at the cancer statistics, and I like that because it's the general population, it isn't that anecdotal story. In bladder cancer survivability in the United States is pretty close to 99% with treatment. In those other two countries, total combined, it's 75. And you know what? It's the same for breast cancer. It's the same for cervical cancer. It's the same for skin cancer. Why? Because they made the trade-off that we're going to stretch this queen sheet over a king-size bed, and we will accept in those countries the fact that some of our young women are going to die of breast cancer. We'll accept that. That's the trade-off that they made. That's what the trade-off this bill presents America. That's why I think if we work together and start saying, listen, we're not going to get it. Let's not even draw that line in the sand. We will not allow a bureaucrat or a politician to get in the middle between that doctor and that patient so they can survive. And I'd yield my time to the doctor from Georgia.
Well, I thank the gentleman for yielding. And what the gentleman is talking about, Mr. Chairman, my colleagues, he's talking about the art of medicine. Medicine is not an exact science. And those practitioners of the art who are really good at physical diagnosis and understand patients and understand what signs and symptoms mean, with this bill, with this ability for the Center for Quality Improvement to mandate, you take away that art from the practitioner. And even more serious maybe than that is those people in our society with chronic illnesses, they're going to suffer because when bureaucrats are in search of revenues, that's when they're going to deny coverage. And I appreciate the gentleman for yielding. I think, as we've pointed out, this is a good, common sense, straightforward amendment that lets people, practitioners of the art of medicine, continue to make the final decision.
Gentleman's time has expired. Mr. Dingell.
Mr. Chairman, thank you. I'd like to direct some questions to the staff about this. There's a couple of interesting words here that concern me here. First, nothing in this section shall be construed. Let's take first the word section. What does the word section cover?
It refers to Section 931 of the Public Health Service Act as added by.
So it covers the whole Public Health Service Act?
No, sir. Section 931 of the Public Health Service.
Okay, what does that do?
It's a new Center for Quality Improvement established by this bill.
All right. And then it says, shall allow any federal employee or political appointee to, who would those be? That'd be anybody. It'd be a food and drug inspector. Could be the secretary of HHS. It could be the director of, rather the administrator of the Social Security program. It could be CMS. Who else could it be?
Mr. Dingell, the provision is would be broadly construed as any federal employee. That could include, for instance, the Commissioner of Food and Drugs or the Director of the Centers for Disease Control or the Director of the National Cancer Institute.
So anybody in the federal government dealing then with federal law would not be able to do anything that would be construed to dictate how a medical provider practices medicine. Is that right?
Yes, sir.
Now, who would a medical provider be? Medical provider could be a doctor.
Yes, sir.
Medical provider could be a nurse.
Yes, sir.
Medical provider could be a doctor on the floor in a hospital who was going to decide when a person was going to get a particular shot.
Yes, sir.
And what would this relate to the handling of controlled substances?
To the extent that it is otherwise covered in this section,
Okay.
yes, sir.
It could relate to food and drug, saying you can't give this particular drug because it's unsafe, or it is outside the approval that has been given by Food and Drug. Is that right?
To the extent that it is otherwise covered by this section,
All right.
yes, sir.
Now it could include a wide array of other people. It could include nursing homes.
Yes, sir.
Hospitals.
Yes, sir.
Could it include laboratories?
Yes, sir.
So if and could it include anything in relation to billing practices?
I'm sorry, sir, I don't know. It's about a medical provider practicing medicine, and I don't know if that's considered a billing practice.
And could it relate to who is qualified to administer a particular treatment? We have quite a fight going on between the nurse the anesthesiologists and the nurse anesthesiologists. Could this relate to the making of a decision and that kind of matter?
To the extent that it is otherwise covered by this section, yes, sir.
So what is the sweep of this amendment? It virtually says that the administrator, the Social Security administration, the head of CMS can't address questions like what kinds of activities are permitted to be practiced, whether an individual is going to get a shot at a particular time or not, whether or not steps are taken with regard to seeing to it that a patient doesn't get bed sores because he or she is not rotated enough. Isn't that so?
To the extent that it's otherwise provided for in the section, yes, sir.
And so it might also prohibit Food and Drug from saying that a particular unsafe pharmaceutical can't be used or has to be recalled?
To the extent that it's otherwise provided for in this section, yes, sir.
Mr. Chairman, I think we have a dangerous amendment here. And probably needs some rather extensive redrafting. I yield back the balance of my time.
Gentleman yields back the balance of his time. Further discussion? Gentlelady from Tennessee.
Thank you, Mr. Chairman. I do support the Gingrey amendment. And over the years, whether I was a state senator in Tennessee, where we have had to deal with the funding of the TennCare program, or here in Congress, I've always looked at these issues and I've said, how do we preserve access to affordable, quality health care for Tennesseans, for my constituents, for Americans? And I think that that is at the crux of what we are dealing with as we look at this legislation. Now, some of us are very concerned that we have a bill that is going to put the bureaucrat in the exam room between the patient and the doctor. And of course, we have had so many people go through this, the different provisions that have been bandied about, not the written legislation because that made it to us late, but everyone says the patient is left out of this equation. And certainly when we hear some of our colleagues across the aisle talk about how is this going to be paid for? How is it going to be funded? Well, we're going to raise taxes, and the wealthy are going to have to pay, small businesses are going to have to pay, and seniors, Medicare, we're going to achieve savings from Medicare, and that is going to be used to help offset the increased cost of this national health plan. And those seniors fear rationing. And they are talking about it a lot, and I'm very grateful that they're talking to us about their fears. They are afraid of losing access. So are parents of children that have chronic diseases that need ongoing care. They are very concerned about the restrictions and the caps that are going to be placed on care that are going to deny those children access to those processes. And I am very grateful that Mr. Gingrey has brought this amendment forward to say, look, you can't do that. You cannot let a bureaucrat practice medicine and make those decisions. They cannot interfere with the practice of medicine. And I am very pleased that he's brought this amendment forward. The amendment deals with Section 931 of the Public Health Service Act, not the whole act. That section that deals with the Center for Quality Improvements. And I think that's important for us to realize, that you can't have a bureaucrat making those decisions. I'm appreciative of the amendment and of his efforts to make certain that this legislation moves to being something that is patient-centered, rather than something that is going to be more power to the government. And with that, I yield the balance of my time to Mr. Gingrey.
I thank the gentlelady from Tennessee for yielding to me, and I want to address some of the questions that the distinguished Chairman Emeritus asked of counsel, and I certainly appreciate the depth of his experience, and those questions needed to be asked. But as the gentlelady from Tennessee points out, Mr. Chairman, this is a very narrowly drawn amendment, and it is applicable to Section 931. And let me just repeat it. This amendment would prevent any federal employee or political appointee to dictate how a medical provider practices medicine as a result of the development of best practices by the Center for Quality Improvement. A bureaucrat could not use best practices defined by this new center to dictate what a doctor could do. And with that, I yield back to the gentlewoman from Tennessee.
And I yield back my time.
Gentlelady yields back her time. Mr. Doyle.
Thank you, Mr. Chairman. You know, it's always amusing to me when you hear this argument that we don't want to let bureaucrats make these decisions for patients, like the current system is somehow lets patients and doctors make these decisions. I'd love to see a poll of Americans and ask them whether they'd like to see someone down here in Washington with no profit motive make a decision on what gets paid for versus a bean counter at an insurance company, because that's the comparisons we're talking about today. Mrs. Blackburn just said that parents of kids with chronic conditions fear this bill because of the caps on care that it will impose on it. I want to ask counsel a question. What does the bill say about annual and lifetime caps on health insurance coverage?
I believe that other portions of the bill, not Division C before us, do not allow for annual or lifetime.
Right. In Division A, does it not ban, does it not say that annual and lifetime caps on health insurance coverage? The answer is it bans them in Division A. Does it not?
Yes.
So the very thing that some of my friends are worried about over there is taken care of in this bill. Let's have another reality check here, too. I hear someone say that, you know, people are going to be forced into this public plan. The companies with 100 can just dump their employees down into this public plan. Number one, it will be probably at least 8 years before that can happen, and it's up to the Secretary of HHS to make that determination. But once someone makes the decision to go into the health exchange, there's going to be a whole list of private companies as well as one quality public plan. So no one's going to be forced into this public plan. If people want to go in, you know, if people go into the health exchange, they make the decision. Once their employer says we're going into the exchange, they make the decision what plan they pick, and they're going to pick from a dozen plans. They can pick any one of probably a dozen private plans and stay in private insurance. Nobody forces them into public insurance. So let's at least get the, you know, get the terms of this debate straight. Nobody's being forced into anything, and I'd rather have somebody here in Washington without a profit mode making a decision who pays for my health care than any bean counter in the insurance industry. I can tell you time after time, the insurance industry has done a disservice.
Mike, would you?
I'll yield to the chairman.
I appreciate you yielding. I was hoping you'd yield to Dr. Christensen, and before you do, I just wanted to point out that the American Medical Association has sent a letter in support of this legislation, and it's hard. The American Medical Association, and they support this legislation because it is key to an effective, comprehensive health system reform. I hope you yield to the...
yeah, and I'll be glad to yield to my colleague from the Virgin Islands.
Thank you, Representative Doyle. As a family physician, I'm very adverse to being dictated to us how to practice medicine, but I've read this section, this 931, Section 931 over and over again, and I see nothing in there that suggests that anyone in the federal government would have any authority to dictate to a provider how to practice medicine, and certainly nothing in there that would even suggest that there would be any support for any kind of rationing of care. As a matter of fact, in the implementation, it speaks to what sounds like a voluntary arrangements within a state or region to implement the practices and some incentivizing of those entities that enter into those agreements. And so I oppose the amendment, and I think that a lot of the concerns that have been raised are really not even relevant to this particular section, but there's nothing in here that would even suggest that someone would get in between, a federal employee would get in between the patient and their doctor. I yield back.
Wish to yield time to another colleague that might seek to talk further? No, do you have time? You want to yield?
Yes, I'd like to yield to Mr. Stupak.
Okay.
Mr. Chairman, briefly, as Chairman of Oversight Investigations, we just had an investigation on this, on insurance rescission. There are 16 million Americans who buy individual policies, and what happens when they get sick. The insurance companies have somewhere between 1,400 to 2,000 codes, which triggers a rejection of their policy because it may cost the insurance company too much money. And if you reflect back upon that testimony, the big three insurance companies indicated they saved $300 million by rejecting, by doing a post-market review. So when you get sick and you submit a prescription, or as Mr. Rogers said, you had blood in your urine, which may lead to something more serious, they automatically reject you. And we asked them to stop the practice of rescinding insurance policies once Americans get sick. The big three sat right there and they told us, no, we're going to continue. We'll continue, and the only way to solve it is to have national health insurance.
Mr. Chairman.
Much like the program you put forth here, Mr. Chairman. So for all the reasons, we should reject this amendment and move on with this debate on more meaningful things and not automatically reject Americans who may get ill.
Gentleman's time is expired. Who seeks recognition? Gentleman from
I'll go after
Oregon.
Mr. Walden.
Thank you, Mr. Chairman. I move to strike the last word. I just want to make a point about the Lewin report, independent, nonpartisan, indicates under this legislation 114 million Americans, 2 out of 3 that have insurance today, won't have the insurance they have today if this becomes law. Now, I was a small business owner for 21 years and 8 months. I've signed the front side of a payroll check. I understand the cost of health insurance and providing it. I've evaluated the penalty here on small employers. I can't run a calculation where it makes financial sense for a small employer to continue to provide health care the way this is crafted. If your payroll is $300,000 a year, your penalty is 2%, if I'm reading this right. Health insurance costs are probably 12%. And so I've been trying to figure out all weekend as I've been working through this bill, this is a perverse incentive that will encourage those who are providing health insurance today to stop providing it because it's multiples times cheaper to pay the penalty than to continue to provide and operate under this government mandate. And so I think you may not believe that that's what will happen out there and that economics doesn't work in the real world, but I think they do. I think economic principles continue, and I think employers are going to make some tough choices, especially in a down economy, and where they're faced with a mandate, by the way, that if they go along with this requires them to provide not only health insurance for the employee but also for the family, and pay 72.5%, I believe it is, or 75% for the employee and 60-some% for the family. If they're not doing family coverage now, that's a huge additional cost under this bill, and so it's even more of an incentive to pay the 2 or 3 or 4 or 5% and opt out. So you are destroying the health care opportunity that's out there today for people who have it through their employer. That's going to go away. Everybody's going to be put in the exchange. And with that, I would yield to the gentleman from Michigan, Mr. Rogers.
Yeah, I just wanted to clarify to the gentleman from Michigan that the health care did pay for it then, but it would not have fit the profile under what the government-run care has to do a checklist of things that are approved as a best practice or comparative effectiveness, because it wouldn't, by statistic, wouldn't have met their threshold. That's the danger of it. And I'll just tell you again, I'm going to read all of the cancers, and this was put out by the National Cancer Intelligence Center and the Canadian Cancer Registry. I'm just going to read them all. These are double-digit, less survivability rate in those countries because they make the choice of not covering certain things. They say they're willing to have people have a higher mortality rate when you get these cancers because they're going to provide government-run care. I'm just going to read them down. Prostate, skin, breast, bladder, cervical, kidney, non-Hodgkin lymphoma, colon, leukemia, ovary, melanoma, brain, stomach, esophagus, lung, and pancreas. They've decided in those countries, given what their priorities are, they are willing to have more people die from these cancers in order to cover other people. What we're saying is we're trying to cover 15% of the people. This amendment gets right to the heart of this bill. Stay out of the patient-doctor relationship. And the only way that they can have shown to do it in these very civilized government-run healthcare systems is by rationing care. It's the only way they can contain costs. And so when you take 100 million people, take them off of their private health care, put them onto this government plan, guess what? They're going to have to ration care. And how do they do that? They do it with your best practices checklists and your comparative effectiveness checklists. That's how they do it. That's what Nice did. That's what this is proposing to do, and that's why we have to set a tone very clear up front, if that's what you're saying is true, that we won't put up with that in the United States of America. I yield back my time.
Would the gentleman yield to me right here?
I would yield to the gentleman from Georgia, Mr. Deal.
I want to ask counsel some questions. You've been asked some hypotheticals as it relates to this amendment. I want to ask you some very specifics as it relates to this amendment. This is an amendment that relates to Section 931. Is there anything in Section 931 that would take away the authority of the FDA to regulate drugs or devices?
Under other existing statutes, no, sir.
Is there anything that under this 931 that would change the regulatory scheme for dangerous drugs, for Schedule 2 or 3 drugs?
Under other existing statutes, no, sir.
Not in this?
No, sir.
All right. Is there anything in this section that deals with changing the scope of practice as to what a nurse or a doctor can do?
Under other existing statutes, no, sir.
But not under this one?
I mean to say that if there are authorities under other existing statutes, they would remain unchanged by this one, by this amendment.
And this amendment would not change any of the law relating to any of those subjects, would it?
All I'm trying to do is to reserve that there may not be current law on some of these topics, but to the extent that there is current law on the topics that you are laying out, this amendment would not change those other statutes.
Thank you.
Will the gentleman yield?
It's just
Time has expired. Now we'll go to the Democratic side. Ms. Eshoo?
Thank you, Mr. Chairman. I move to strike the last word. On this issue of caps, if you read the bill, the lifetime limit on caps has been lifted. And this is a very important provision in the bill. Back in 1996, I introduced legislation and called at that time Christopher Reeve, who was still alive, and asked if he would allow his name to be placed on the bill. He obviously was a very good example of someone who incurred something that was catastrophic. Most people don't realize what's in their insurance policies. Where this is acutely experienced and felt is in the disabled community. And so I think it's important to note that has been cured in this bill. Now, members have made reference to the Lewin report. The Lewin report was written months before this provision became part of the underlying legislation. And I think it's also important for members, if you don't know this, you'll find it interesting. If you do, it's a refresher, and that is that the Lewin organization is owned by United Healthcare. United Healthcare was the one that came before the Investigations and Oversight Subcommittee and said, no, we're not changing our practices for rescissions. So come on, let's get our facts straight. I know that we have philosophical differences. They should be debated and debated really well, but we need to deal with the facts. So when you're talking about caps, the caps are no longer going to be in existence, and I think the American people are going to be 1,000% better off as a result of that. Thank you, and I yield back.
Yes, Mr. Blunt.
Thank you, Mr. Chairman. I gave some thought to debating the amendment here, but since no one else appears to want to do that, maybe that would be out of character. This amendment, if I read it right, just deals with federal employees, not directing insurance companies, but directing medical professionals. Now, I heard somebody on the other side say they'd like that. My guess is most Americans would not like a detached bureaucrat that had a bad day the day before to make that decision instead of their doctor. That's all this is about. There are other sections of the bill that deal with insurance companies. And in fact, I think you'd find substantial across the whole committee interest in making the insurance system more competitive, making it more responsive. Competition has impact on price. The way the current system grew up, it grew up to where you really don't have the kind of marketplace that we could pretty easily achieve. I think our concern on that topic is different than this concern, and it's great. And, you know, many of us believe that the government as a competitor cannot compete fairly. The Lewin Group, by the way, has been around over 4 decades. It is always described as a left-of-center health care group, slightly left-of-center, pretty close to the middle, but it's never been described as conservative or right-of-center. It's well respected as a group. There have been 2 studies. The first one on the Kennedy bill, I think, said 160 million people would leave their insurance. On this bill, they said 114 to 125, and that study was less than 2 weeks ago. Now, I realize this bill was only less than like 2 or 3 days ago, but it was pretty close to this bill. I mean, it's hard to score this bill when you don't see this bill. And to then have that thrown up to us that nobody has scored this bill yet, that they scored a bill 2 weeks ago instead of this bill, everybody believes that if you have a public competitor that is at somewhere near Medicare, that the private competitors will get smaller and they will eventually go out of existence. That's another debate. This is a debate about whether a federal bureaucrat can dictate to a medical provider medicine practice decisions. That's all this amendment's about. It's not about insurance companies. It's about a federal bureaucrat and medical practitioners. We can have all the debate on the other parts of the bill we want to, but that's not what Dr. Gingry's bill deals with. And I would hope that this committee would decide that the doctor-patient relationship is more important than the bureaucrat-patient relationship, and I support the amendment. I would yield to Chairman.
I thank the gentleman. I want to reiterate what Congressman Blunt just said. This is about practice of medicine. That's what this amendment's about. It's about the practice that's in I would use the word innocuous. If I ask for a show of hands, how many people think somebody in Washington should tell your doctor how to practice medicine on you? I don't think anybody raised their hand. I wouldn't raise my hand. I don't want my doctor to be told how to practice medicine on me or my family. And that's all Dr. Gingry's trying to do.
Would the gentleman yield?
If I'm allowed the second-degree yield, I'll yield. Sure.
I think that the difference in the argument here is who's standing between patients and their doctors.
We don't want anybody to stand between patients and their doctors.
We believe on this side of the aisle that insurers do time and time again. I haven't met over the phone a really bubbly, pleasant, welcoming, helpful bureaucrat from an insurance company. I have to tell you that.
Well,
I dealt with a lot of them when I still had my mother and father. So, you know, this idea that there are just bad guys in the government and good guys every place else, I think it's just overly simplistic. But I appreciate you giving me some time.
Reclaiming Mr. Blunt's time for me to use. I have, unfortunately, because of some health problems I've had in the last 3 or 4 years, I've been in several examination rooms and even a few hospitals with various ailments. I've never had an insurance agent in the examination room or in the hospital room when my doctor or doctors were in there trying to discern what was wrong with me and then what to do about it and then implementing their strategy. Again, if we want to have a debate about insurance companies, I have a feeling some of us on this side would, in fact, I know I support Mr. Stupak and his investigation on the rescission stuff, but this is about doctors, patients, doctors practicing medicine. If you think the doctor should be able to practice the best medicine he or she knows how on you and your family, vote for Dr. Gingry. If you think they shouldn't be allowed to, vote against him. It's that simple.
Gentleman's time has expired. Is there further debate on the amendment?
Mr. Chairman.
On the Democratic side, no one seeks recognition. Mr. Braley?
Yes, I'd like to ask my good friend from Georgia a question. Isn't it true that the harm you are trying to prevent with your amendment is already prohibited by the 10th Amendment to the Constitution?
Well, if you can explain to me what you mean by that, explain to me what you think the 10th Amendment says in regard to preventing harm.
Absolutely. The 10th Amendment to the Constitution reserves to the states all rights that are not specifically spelled out to the United States or that aren't prohibited to the states. And we all know that right now the practice of medicine is regulated in all 50 states. So in your amendment, you're trying to prohibit a practice that already is prohibited by the 10th Amendment. Isn't that correct?
The gentleman yielding back to me in regard to that, and I thank him for the question, and I guess then the gentleman was for the First Amendment that was offered by my colleague from Georgia, Representative Deal, the ranking member of the Health Subcommittee, when he brought up that point maybe an hour ago, the fact that the states have that right as protected by the 10th Amendment. But we heard General Counsel say that that absolutely under this bill that the states could be preempted by under this section by the Center for Quality Improvement. It says, well, all plans for state employees have to cover certain mandates, maybe including abortion coverage. So, I mean, I'm glad you asked me the question, quite honestly, and I'll be glad to answer any other you might have.
I'll reclaim my time. I think that the bottom line is that the purpose of the amendment is already protected under the Constitution because nothing that we do in a federal statute can interfere with the constitutionally protected rights of the state to control the practice of medicine. That's the way the Constitution applies to the practice of medicine right now. And I also want to talk about this issue of comparative effectiveness research, and especially its impact on breast cancer patients. And I want to share with you a situation that conveys why comparative effectiveness research is so important. In 1981, a well-known doctor, William Peters, who was working as a fellow at Dana-Farber Cancer Institute in Boston, developed an experimental breast cancer therapy involving high-dose chemotherapy with bone marrow transplant. And Dr. Peters came here and probably presented a presentation to some of the members of this committee, and he said that if they did not pass approval for this experimental but very expensive treatment, the 70 breast cancer patients in the audience, half of them would be dead within a year. And he told members of Congress, as you look at a woman across the table from you, ask yourself, is the price of this woman's life worth the price of a luxury car? Well, here's the rest of the story. Dr. Peters worked with another physician named Craig Henderson at Dana-Farber, and he warned Dr. Peters against accepting high-dose chemotherapy without independent validation, and he was ostracized by his colleagues for his warnings. And yet Dr. Peters, the one who invented this treatment, became concerned enough that in 1991 he convinced the National Cancer Institute to fund a clinical trial to make sure that his treatment was safe and that it was effective. So 5 different clinical trials were presented in the summer of 1999 at the annual meeting of the American Society of Clinical Oncology. Those 5 clinical trials found no advantages in outcomes between conventional treatment and high-dose chemotherapy with bone marrow transplant. So what was the price? Well, roughly 42,000 women, 30,000 in the 1990s alone, were subjected to the risk of this entirely experimental treatment. $3.4 billion was spent on the procedures, and they later determined that 9,000 of those patients died not from their cancer, but from the treatment that they hoped would be their cure. That's why comparative effectiveness research is important, and that's why it's important to make sure that we have it in this bill and that it is unbiased and people can rely on it. And I'll yield back my time.
Gentleman yields back his time. Are we ready for the question? We've had a lot of debate on this
Mr. Chairman.
amendment. Who seeks recognition?
I do.
Mr. Hall, I'm going to recognize you, and then I'd ask you, if you would, to yield to others who are seeking recognition on your side. I think
I
most
think
of them
it's
have
going to
already
take my
talked.
full 5 minutes to say what I want to say. What are you telling me to do? I guess I'm going to do what you tell me to do.
No, Mr. Hall, you're recognized. You've got your 5 minutes.
It's okay
But if you don't use it
start?
all, yield to some of the others on your side.
But we talk about the 10th Amendment and all that. Even the Second Amendment is just 27 words, and there's been millions and millions and millions of statements made about it. This amendment is so simple that there's not a high school kid in the United States that couldn't understand it. And here we are, we've talked almost an hour and a half or maybe 2 hours on it. It simply says nothing in this section shall be construed to allow any federal employee, now think about a federal employee first, or a political appointee, get him over here or her, to dictate how a medical provider, he's in the middle, how he practices medicine. Well, you've read that. That's simple. Is anybody anywhere that doesn't understand what that says? Now, you have to construe this act based on the most simple medical practice. That's maybe delivering a baby, or the most severe or serious medical practice, a coronary bypass. I just wonder who'd be the most capable federal employee up here? Probably the architect of the Capitol. He may be. I don't think you'd want him making any kind of decision like that. Who'd be the greatest political appointee? I don't know if it's a guy that has control of the trade for all the other nations in the world. He's from Dallas, Texas, a very smart guy. I don't think you want him telling you, doctor. The question is, would you want any federal employee to tell Dr. Coburn, Senator Coburn over here, who delivers babies, goes back to Oklahoma every week and delivers babies, would you want the architect of the Capitol telling Dr. Coburn how to deliver a baby? I don't think you would. Would you want any political appointee, any of them, you pick any of these that Obama's appointed, would you want any of them to tell the late Dr. DeBakey how the coronary bypass ought to be run? That's absurd and ignorant. Reread the construction here. Nothing in this section shall be construed to allow any federal employee, the architect, or political appointee to dictate how a medical provider, that's Dr. Coburn or maybe Dr. DeBakey, the late Dr. DeBakey, it's that simple. And I don't know why we have all the problem with all this. If you're trying to knock insurance companies, of course insurance companies try not to pay losses. The plaintiff's lawyer is trying to say that an ingrown toenail makes him total and permanent. But the medical doctor that testifies for the insurance company sometimes will testify that if he had a leg off, it might grow back. That's law business. Here is so simple that anybody in the world ought to could read this and vote aye on this amendment.
Will
I yield back my time.
Will the gentleman yield?
Yes, I do yield back to you, Doctor.
A couple of quick things. When I was a state senator in Pennsylvania, I wrote the Pennsylvania Patient Bill of Rights. And that was to deal with the issues with managed care because insurance companies were making a lot of decisions and having people who did not practice medicine take over the decisions of medicine. The government is going to get into the insurance business. And we have to understand if that which is not specifically forbidden is permitted. This specifically forbids it, otherwise it would be permitted. And I would hope my colleagues be cognizant that if the government wants to get into the insurance business, we should make sure we do not repeat the mistake that occurred before with the insurance business with managed care.
Gentlemen, yield to me now, Mr. Hall. Mr. Hall?
Yeah. Thank you, Mr. Chairman. I yield back my time.
Why don't you yield to Mr. Boyer, because otherwise he'll get...
Yes, sir. I yield to Mr. Boyer.
All right. This is my question to counsel. If we're trying to figure out intended and unintended consequences of this, if in fact we're going to have the Center for Quality Improvement that will set, quote, best practices, will it be setting standards and thereby having an impact upon medical liability that uses community standards?
Mr. Boyer, the provision in this section is to identify best practices. It does not have an ability to set enforceable standards for any practitioner, nor does it have the authority to set community standards for liability concerns. There are no enforcement provisions within this section. It is to develop research to identify best practices and then to promulgate those best practices through grants and contracts.
I think that's very helpful to us. None of us want anything to come between our doctor and a patient or ourselves, and that's what Mr. Gingrey's is about. We don't want there to be a government board that's going to mandate these standards. And you're telling me that's not in this law?
Not in,
Mr. Chairman,
then everybody should support Gingrey's amendment.
Mr. Chairman, I'm not going to yield back to anybody else. I just want to simply close with rereading this. Nothing in this section shall be construed to allow any architect or any political appointment, the Secretary of the Treasurer, to dictate how a medical provider practices medicine. Read it and then vote.
Gentleman's time has expired. Are we ready for the vote? Gentleman from Louisiana seeks recognition.
Thank you, Mr. Chairman. First, I want to enter into the record, make unanimous consent that this report from the Louisiana State Medical Society that just came out opposing this legislation be entered into the record. And I'll quote, they say, a number of reasons that they cite, but they say, finally, the most radical of the bill's provisions, the public plan option, is clearly against Louisiana State Medical Society policy, which is in opposition to a national single-payer health insurance system. The public plan option represents a gateway to a vast expansion of government control of the nation's health care system and is the stalking horse of a thriving competitive insurance marketplace. So clearly, maybe what we've touched on is a nerve here, the fact that there's so much debate, but the biggest concern many of us have expressed over a government-run plan is looking at the history of the other countries that have this. And you look at Canada, you look at England, places that have the experiences, the first thing they've done is they've rationed health care for their people in their countries. And those
Gentlemen, yield to me.
I would yield to the
You don't
chairman.
think we have rationing in this country? There are people who can't get access to any medical care because the insurance companies won't cover them, and they have nowhere to go.
And reclaiming my
That is
time,
the
in your bill, you
starkest
actually
kind of
tax those people. Right here on page 167, you actually tax those people that are uninsured. The Congressional Budget Office said you impose $29 billion in new taxes on people who are currently uninsured. That's on page 167 of the bill. So you're actually taxing people. Congressional Budget Office said $29 billion who are uninsured. But go to section 2401.
The gentleman support the
I support the amendment because what it does is it actually shines the light on the fact that this bill is going to ration care. This bill interferes with the relationship between a doctor and their patient, and I'll just show the organizational chart of this bill. If anybody can show and look at this organizational chart and say that government isn't interfering between the doctor and patient relationship, then you haven't seen. This is the patient and this is the doctor, and these are all the bureaucracies that are being set up in this bill that get in between the doctor and the patient. It's in the bill. And so what Mr. Gingrey is doing, Dr. Gingrey is doing, is saying, remove all of these federal bureaucrats away from the relationship so that the doctor and the patient can choose what's best for that patient. Instead of what Canada does, instead of what England does, we've got those experiences. We see what they do, and I'd be happy to yield to my friend, the doctor from Georgia.
Well, Mr. Chairman, I thank the gentleman from Louisiana for yielding, and I want to bring up a point in regard to his point about Louisiana Medical Society not supporting this bill and their concerns over the public option. I will tell you that my state of Georgia feels the same way and is leading a coalition of about 16 other states that are all part of the American Medical Association that do not support this bill because of the government option. And so, the chairman mentioned and others have mentioned the support of the AMA. Great organization. Represents about a fourth of the physicians in the United States. So, I don't think that speaks to all of the practicing doctors. But let me just say this as we come to, I think, near a conclusion of this debate, Mr. Chairman, on my amendment. The arguments that I've heard in the last 30, 45 minutes from the other side is nothing but an attack on the insurance industry. Look, we can agree with a lot of things in this legislation, certainly ending this practice of rescission of a policy after a person is in the hospital on the operating table, saying that because some technical glitch in the way they filled out their application, they're denied coverage. We agree with that. We agree with most of the insurance industry reform that's in the bill. Not denial of coverage for pre-existing conditions, community rating. We agree with the need for electronic medical records, transparency. We agree for equalized tax treatment of the purchase of health insurance so that individuals and people that are employed in a small company get treated fairly. We agree with all these things. But the problem as we reform the insurance industry is we are morphing into a situation where we have a new insurance company that needs to be reined in. And that insurance company is the federal government. Boss hog telling doctors what they can do in treating patients to the best of their ability.
Will the gentleman yield?
Chairman, I yield back to the...
Will the gentleman yield?
Hard to top that, but I yield to my friend from Arizona, Mr. Shattuck.
Will the gentleman yield to me for a question of Mr. Gingrey?
Yield, Chairman.
Yes, Mr. Chairman.
I want to know, since we've already had Medicare in operation for a very long time, has Medicare told the doctor, or any bureaucrat at Medicare told the doctor how to practice medicine, dictate how medical providers practice medicine? Has that been your experience? Have you heard problems about that?
Mr. Chairman, no question about it. They do that by forcing the doctors to, to either accept Medicare, accept assignment, or have their reimbursement cut significantly less.
That's not the practice of medicine. That's the practice of reimbursement. Your amendment goes to the practice of medicine. We have a government-run health insurance program for seniors called Medicare. It's been in operation adopted since 1965. Does Medicare tell doctors how to practice medicine?
Absolutely. Medicare can deny coverage.
Deny
access.
Yes,
they can.
The gentleman's time has expired. Let's proceed to the vote. All those in favor of the Gingrey amendment say aye. All those opposed say no. The noes have it. Roll call is requested. Let's go to a roll call.
Mr. Waxman?
No.
Mr. Waxman, no. Mr. Dingle? Mr. Dingle votes no. Mr. Markey? Mr. Markey, no. Mr. Boucher? Mr. Pallone? Mr. Pallone, no. Mr. Gordon? Mr. Gordon, no. Mr. Rush? Mr. Rush, no. Ms. Eshue? Ms. Eshue, no. Mr. Stupak? Mr. Stupak, no. Mr. Engel? Mr. Engel, no. Mr. Green? Mr. Green votes no. Ms. DeGette? Ms. DeGette votes no. Mrs. Capps? Mrs. Capps, no. Mr. Doyle? Mr. Doyle, no. Ms. Harmon? Ms. Schakowsky? Ms. Schakowsky, no. Mr. Gonzalez? Mr. Gonzalez, no. Mr. Inslee? Mr. Inslee, no. Ms. Baldwin? Ms. Baldwin, no. Mr. Ross? Mr. Ross, no. Mr. Weiner? Mr. Weiner, no. Mr. Matheson? Mr. Matheson, no. Mr. Butterfield? Mr. Butterfield, no. Mr. Melanson? Mr. Melanson, no. Mr. Barrow? Mr. Barrow, aye. Mr. Hill? Mr. Hill, no. Ms. Matsui? Ms. Matsui votes no. Mrs. Christensen? Mrs. Christensen, no. Ms. Castor? Ms. Castor, no. Mr. Sarbanes? Mr. Sarbanes, no. Mr. Murphy of Connecticut? Mr. Murphy, no. Mr. Space? Mr. Space votes no. Mr. McNerney? Mr. McNerney, no. Ms. Sutton? Ms. Sutton, no. Mr. Braley? Mr. Braley, no. Mr. Welch? Mr. Welch, no. Mr. Barton? Mr. Barton votes aye. Mr. Hall? Mr. Hall, aye. Mr. Upton? Mr. Upton, aye. Mr. Stearns? Mr. Stearns, aye. Mr. Deal? Mr. Deal, aye. Mr. Whitfield? Mr. Whitfield, aye. Mr. Shimkus? Mr. Shimkus, aye. Mr. Shattuck? Mr. Shattuck, aye. Mr. Blunt? Mr. Blunt votes aye. Mr. Boyer. Mr. Boyer, aye. Mr. Radonovich. Mr. Radonovich, aye. Mr. Pitts. Mr. Pitts, aye. Ms. Bono-Mack. Ms. Bono-Mack, aye. Mr. Walden. Aye. Mr. Walden, aye. Mr. Terry. Aye. Mr. Terry, aye. Mr. Rogers. Aye. Mr. Rogers, aye. Mrs. Myrick. Mrs. Myrick, aye. Mr. Sullivan. Mr. Sullivan votes aye. Mr. Murphy, Pennsylvania. Mr. Murphy, aye. Mr. Burgess. Aye. Mr. Burgess, aye. Ms. Blackburn. Aye. Ms. Blackburn, aye. Mr. Gingrey.
Aye.
Mr. Gingrey, aye. Mr. Scalise.
Aye.
Mr. Scalise, aye.
Have all members responded to the call of the roll? If so, the clerk will tally the vote. Yes.
Mr. Chairman, on that vote, there were 24 ayes and 33 noes.
24 ayes, 33 noes. The amendment is not agreed to. We have votes now on the House floor. We will take a recess, and I urge members to return for the markup as soon as we complete the last vote on the floor.
And, Mr. Chairman, what time do you think we'll conclude this evening?
We'll go, I think, till 11 or 12, or maybe longer if we're going to take as much time on the debate on every amendment.
I just need to know how much coffee to drink, Mr. Chairman.
Stand in recess.